Welcome back. Welcome back, everyone. I hope you had a refreshing break. I would now like to hand it over to my colleague, Jennifer Stowell, who will moderate our second session.
Thank you, Azar. So we're going to start off this morning. Our first speaker will be Moiz Usmani from the University of Florida, and he'll be talking to us about the sustainability of coastal health and climate variability. And just a reminder to those presenting, if your presentation is running long, you will get a little notification.
Thank you, Jennifer, for the introduction. And hello, everyone. My name is Moiz Usmani. I'm a postdoctoral research associate in University of Florida. I'm working with Dr. Antipri Jutla and Dr. Rita Colvin. So let's start. So with climate variability, we have seen emergence, prevalence, and distribution of various diseases and infection around the globe. So today we'll look into the coastal health. So first, we'll look into the biggest challenges when we talk about coastal health in terms of infections. So nearly around 7.2 million cases of water-related diseases are reported in the United States. Although all of them are not coastal, but around 80,000 infections or illness and 100 deaths annually in the United States are due to the coastal infections. And these infections are mainly caused by Vibrio species, which are pathogenic bacteria native to warm and brackish water. So some of the common infectious Vibrios are Vibrio cholerae, Vibrio parahemoticus, and Vibrio vulnificus. And among these Vibrios, Vibrio vulnificus has the highest mortality rate. Yes, and on the right side, you can see there's a recent study that came out last year suggested that there's a latitudinal shift to the confirmed water-based Vibrio vulnificus infections in USA. In the last 30 years, the prevalence of these Vibrios has moved from the northern part of coastal Florida to the coast of New Jersey. So as we know, waterborne infections cannot be eradicated because the pathogens are native to aquatic media and are related to modalities of climate and weather patterns. So waterborne infections occurs only when these pathogens interact with vulnerable population under certain sociological pathways, and therefore recently we see that there's a change in climate, so that can lead to shift in water availability and alter patterns and increase risk of these waterborne illness. So therefore the understanding of the environmental conditions that we have can lead to the increase in Vibrio vulnificus growth and spread, can aid in the development of early warning systems and targeted prevention strategies. I think, yeah. So in 2022, when Hurricane Ian hit the Florida coast, we saw a spike in Vibrio vulnificus cases. Usually we see 20 odd cases around the year in Florida, but within the 1 month after the hurricane made an impact, we saw 31 cases. So what I did, I looked into the Vibrio caused infections in Florida. So on the left side of your screen, you see all the Vibriosis cases, which include Vibrio vulnificus, parahemoticus cholerae, and other Vibrios. And on the right side, we have just Vibrio vulnificus cases. And I did a trend analysis to look into how the cases has changed with respect to time. And yellow and red color represents the increase in trend, which means like the cases has increased with time in the last 22 years. And other shades of blue basically represent there's a decrease in cases. If you look into it, you can see that like around most of the counties in Florida, we see a significant increase in Vibrio vulnificus, Vibriosis cases. And if we look into on the right side of your screen is just for Vibrio vulnificus, and we can see there are 3 different locations like counties around Lee County, then Indian River Lagoon System, and Escambia County, where we see a significant increase in Vibrio vulnificus infections. So I consider Tampa Bay and Galveston Bay for the analysis and investigated the highly associated variables, which are sea surface temperature and chlorophyll, to look into their roles in the emergence and prevalence of these Vibrios. And what I found that these bays, the region around these bays and around these bays have experienced an increase in sea surface temperature and chlorophyll over the period of 18 years. And using statistical methods, we determined an association between the variables and found that sea surface temperature at a lag of 2 months, if it is within a certain range, and then in the next month chlorophyll is within a certain range, then that region will have a high odds or probability to have Vibrio vulnificus. And if there is an interaction between human, that can be through recreation or food or flood, then we can see an increase in Vibrio vulnificus infection cases. Thank you.
Thank you very much. If you'll go ahead and stop sharing screen, we'll go ahead and start off with our next speaker. So we'll be happy to invite Jenny Vanos to start her screen sharing. And oh, I'm so sorry, not Jenny, Lena Easton Calabria from the RAND Corporation. And she's going to be sharing information on indoor heat, housing characteristics, and health in an environmental justice community in New Orleans. And we'll let you take it from there.
Wonderful. Thank you so much. Yeah, I'll just dive right into it. My name is Lena Easton Calabria, and I'm a policy analyst at the RAND Corporation and a PhD student at the University of Oxford. And I will be presenting our work on indoor heat, housing characteristics, and health in an environmental justice community in New Orleans. This is a project that is housed at Johns Hopkins University, and we have many different collaborators, one of whom is IC Change, is a primary collaborator with RAND and Johns Hopkins on this research, and my colleague Caroline Reed will be presenting this afternoon. All right, so just move us along. So our project objectives are outlined here. Our goals are really to understand the home and neighborhood environmental characteristics in New Orleans that increase the risk of health impacts from extreme heat. And we're also aiming to provide evidence to inform public health preparedness during extreme heat events in New Orleans. There we go. So just to give you some background on this study, I'm going to be talking about 3 rounds of data collection we completed last summer, our first rounds of data collection and some of the progress that we are making so far on data analysis. So essentially last summer, we recruited participants in 2 neighborhoods in New Orleans and placed indoor sensors in their homes for 2 weeks at a time that tracked indoor temperature and humidity. These sensors took readings every 15 minutes, and we placed them inside the bedroom of participants because we wanted to be able to capture the the thermal environment when people were sleeping. At the same time, we sent residents multiple surveys every day that actually asked questions about their physical and mental health in the moment they received the survey, asked questions about their sleeping patterns the night before, as well as whether they were home at that current moment and whether they had access to air conditioning. Our participant demographic data, some of it is displayed here. My colleague Caroline Reed will be discussing this in further detail in her presentation. As you can see, we had a primarily Black or African American cohort, also primarily women. And while we do have different educational levels represented here, the majority of our participants did not have a college degree. We had 72 participants in total this past summer, and when we asked, about 80% of participants self-identified as low income. So that's really important background data for actually our data analysis, which is what I'm going to be talking about next. All right, so I mentioned that we were sending these surveys multiple times a day with questions around physical and mental health. So some of these questions asked how happy a person was feeling, how sad, how stressed, tired, or physically uncomfortable they were feeling in the moment. And to simplify the analysis of these responses, we created binary response variables, which is what you can see here, where we grouped not at all with a little and quite a bit with extremely. And then this here is a multivariate odds ratio that's actually based on those groupings. So looking at not at all and a little bit grouped as 1 and extremely and quite a bit also grouped together. We can see that there is a statistically significant pattern here, a statistically significant ratio for the highest temperature range predicting that somebody is physically uncomfortable. That is this line here. The rest of these results, while they're not statistically significant as they cross the one line, when we look at these results alongside the humidity results, which we also produced a multivariate odds ratio for, we can see some sort of pattern emerging around responses to being stressed and tired as well. However, physically uncomfortable in the highest temperature humidity range remains the statistically significant result here. Now, why is this important when we think about environmental justice? So we're at the point where we are in the process of conducting this data analysis. And when we're looking at health and working with communities like these low-income communities in New Orleans, it's really important to remember that reference points have been shown to vary between social groups, and specifically vary between groups when reporting self-reported health symptoms and other issues across and within groups. So what this means for us and what we're thinking about is that, you know, someone like me who has not lived through Hurricane Katrina, what might be extreme for me could be very different than somebody who lived through Katrina, and for them, that's only a little bit uncomfortable or quite a bit. This quote, I think, perfectly encapsulates that reality. One of our participants has stated something to the effect of, "I remember sitting on my roof for over a day after Hurricane Katrina. That was hot." So given this kind of information, sorry about that. We're planning to run a kind of just a test analysis where we actually group the a little responses with quite a bit and extremely. And my main point of highlighting this here is that when working with environmental justice communities, decisions to factor in different aspects of the communities that we're working with happens not only in recruitment and data collection, but also in data analysis. So with that, I will give time to the next speakers. Just wanted to acknowledge our funder, participants, and the PI of this study. Thanks so much.
Thank you very much, Lena. We'll go ahead and invite our next speaker to share slides. We're going to be hearing from Jenny Vanos from Arizona State University, and she'll be talking about quantifying indoor heat stress and strain across climate context and adaptive capacities. And we'll let you take it from there.
Thanks, Jen. All right, thanks for having me. So yeah, this nicely follows up from the previous presentation around indoor heat stress and what it means more for physical health than mental health, but I think they're both important to study in tandem. So we're looking at different climate contexts and adaptive capacities. A lot of motivation for this around understanding that air conditioning is not always present, its functionality is not guaranteed, even if someone has it. And a lot of the cases of indoor heat illness and death can be associated with poor or no air conditioning. For example, in Maricopa County, where Phoenix is located, there's a lot of mobile home indoor deaths, unfortunately. And we also know that heat risk is higher among certain sensitive populations. So it's important to understand how that heat risk differs for people who are young and healthy versus someone who might be an older adult and have or have a pre-existing illness. And then we also know that fans can have different cooling efficacies depending on the climate type, so hot or humid or hot and dry. So with this, we looked at personal heat exposure and stress experienced in both healthy and heat-sensitive populations in dry and humid climates, and the corresponding indoor conditions based on the outdoor conditions changing levels of air conditioning. So we looked at two climates, two building archetypes that are specific to the climate, 3 levels of AC functioning based on the 2021 IECC codes, 2 types of people, young and older, and then we had a fan on or a fan off to look at a total of 48 different thermal exposures in this specific study, and we'll be building it out to more cities and climate types. But so we have the outdoor data extracted and picked a few heat waves. Here's an example of one heat wave in Phoenix showing the dry air temperature, dry bulb temperature, or sorry, solar radiation, dry bulb temperature, and vapor pressure. And then using the Energy Plus model to simulate the indoor building energy, or I guess the indoor temperature, indoor humidities, and indoor mean radiant temperatures. So this is an example of the air temperature indoors and the control compared to if you have no AC. And so one thing takeaway that will stick with you throughout this talk is that at some point in this environment, the indoor actually becomes worse than the outdoor, which is important to remember as we think about thermal inertia of buildings if someone's not changing their behavior. Then what we added on to that was taking that indoor data and applying a partitional colorimetry model, which essentially is just a human heat balance model to look at all the gains and losses from the human body, really focused on where can we lose evaporative heat and where can we lose or gain convective heat. And we looked at whether someone was uncompensable, which means unsafe and their core temperature might begin rising, or compensable or safe. So if we look at the dry heat gain in Phoenix and Miami, what we start to see is that at some point in the afternoon, that given heat wave starts to result in a heat gain to the body, which can have dangerous conditions if the evaporative heat loss can't overcome it. And in this case, what we see when we compare the two climates is that Phoenix has 2 times the potential heat loss compared to Miami in terms of the climate. So that means that Phoenix is a much safer climate to be experiencing high temperatures in, because the body can lose a lot more heat through evaporation than it could in Miami, all else kind of being equal. And so it's important to try and support that evaporative heat loss and stay hydrated so we can continue to sweat. Now, when we kind of put those together and we want to look at the overall heat balance and where it's dangerous, we start to look at when these lines rise above this required skin wetness line. And if the line rises above that, as in this indoor situation in Miami, then we don't have enough required heat loss that's needed to stay in a safe heat balance. So when we look at the use of fans, overall fans support evaporative heat losses at the skin, and so they always lower heat stress in these situations. Even though they can increase convective heat gain in the hot, dry weather, that's overridden by evaporative support from being able to sweat and evaporate that more with a fan. And so with older adults, the risk is higher, as you can see by looking at where these levels rise above the red line with the older adults. And that's where we find more unsafe conditions. Even with the fans, you can still have unsafe conditions, and you have a lot of unsafe conditions without the fans. So the fans do help. So overall, we do need to pay attention to the conditions that rise above outdoor heat levels too, and then what people can do indoors to change their behavior. The presence of AC doesn't always equal safety, but fans do enhance heat loss to alleviate heat stress in most situations, but it's less for older adults due to their sweating restrictions. Thank you.
Thank you very much, Jenny. I'll invite our next speaker to share his screen. We're going to be hearing from Christopher Wajo, I probably got that wrong, from Florida State University, and he's going to be sharing with us information regarding the co-developing of a community and evidence-based heat action plan in the Miami-Dade County in Florida.
Hi, everyone. Thank you for organizing this. Jump right into it. So we're working with Miami-Dade's Chief Heat Officer, Jane Gilbert, who many of you know is the world's first Chief Heat Officer. They had a few questions that we worked on together. The first one, relatively straightforward for this audience, but are heat waves or everyday hot and humid exposures more related or consistently related to excess mortality in Miami-Dade County over this period? As many of you might have guessed, we found evidence that it is actually the everyday or just continuously hot summer season exposures that are more consequential using a distributed lag nonlinear model. Again, happy to take questions later. but essentially a time series analysis which compares the population against itself and controls for slowly adjusting confounders such as socioeconomic status. But essentially, there is a bit of a over this 5-year period, a somewhat consistent effect of the day's heat exposure and the previous 9 days heat exposures on excess mortality, which results in something of a pretty wide range of estimates of who may actually be dying, and that total number, that's going to be something on the order of anywhere from 30 to about 600 per year. The next question is, what are the characteristics of the places that disproportionately suffer from high heat-related illness rates in the county? So time, trying to get at the timing and the disease burden. Question 2, really getting at where. So now we want to do something about it. Where should we target our efforts? Again, this is relatively straightforward work. We used just a spatial regression. We separately looked at emergency department visits and hospitalizations. I'm just showing you emergency department visits in terms of timing today. So here, these are the statistical regression results. We have 20-year average of land surface temperatures from MODIS, and that's being fairly consistently linked to having increased risk of heat-related illness in Miami-Dade County over the period, as well as outdoor workers and age being a bit of a proxy for African-American and family, younger families. Indigenous communities, we do have higher elevated risk for those who are both American Indian or Native American, as well as indigenous Central American, Mayan, things like that. Just to make that less wordy, here's some pictures of that, the actual emergency department rates. These are classified heat-related illness rates, which we know are an underestimate. So the presumption being that they're underestimated relatively similarly across space, which we have Homestead, Plant City, some of the agricultural growing regions down here, central portions of Miami-Dade County, cities, some of the areas that are being gentrified, being hotter. So this combined with a series of community workshops, which are beyond the scope of me being able to present on, but were quite insightful and created their heat action plan, which they created within 2 years of having their starting to work on this topic. So kudos to them. The goal is to inform, prepare, and protect. Number 2, cool our homes and emergency facilities and our neighborhoods. So just a bit of some of the neat stuff they've been doing, really largely Jane Ludvika and others there. But they have a structured outreach and education campaign, multiple mediums, multiple languages. Targeting, some things they're targeting is the public transportation corridors. For those who don't have access to an air-conditioned vehicle. They created resilience hubs, but in Miami-Dade County, the flavor of that looks like a combination of hurricanes resilience and heat resilience. So our hurricane season and our heat season are pretty much the same. Hurricane season going slightly longer, but essentially being a hub. So those hurricane shelters are also going to be our cooling refuge hubs. They've tried to pass unsuccessfully, but certainly kudos to them for trying to pass legislation to protect workers from adverse heat and providing water, rest, and shade, installed 1,700 units in public housing, and have successfully leveraged some of the Inflation Reduction Act with funds for street cooling and trees. So I know I'm at time, but I'm super happy to engage with you further. I appreciate that.
Wonderful. Thank you, Christopher. We'll next invite our next speaker to go ahead and share slides, and we'll be hearing from Ajua Abuaji Okir, which I probably also got wrong. And we'll be learning more about the changing role of dust and wildfire PM 2.5 on Africa's air quality and human health. And I'll let you take it from here.
Okay, hi everyone. My name is Ajua, and today I'm going to talk about how much dust and PM 2.5 have changed over Africa and its impact on its air quality and human health. So a bit of a background, ambient pollution is a major environmental issue, and long-term exposure to PM 2.5 increases the risk of cardiopulmonary diseases and health. It is also responsible for 1 in 9 daily deaths and also between 6 to 7 million deaths globally, annual deaths globally. And currently, about 90% of the global population faces ambient air quality levels that surpasses the air quality guidelines of 5 microgram per meter cube annually, and also the daily exposure level of 10 micrograms per meter cubed. And then currently, most of the studies of air quality primarily focus on anthropogenic PM 2.5. And so whilst the natural aerosols like dust and wildfires have been understudied for their air quality impact, especially over Africa, because most of the data for air quality analysis are limited. So this figure here is showing you how much dust emissions over North Africa has increased since pre-industrial times. So there's been a 51% increase of dust emissions since pre-industrial times. And so what is this impact on the dust concentration, and how is it going to impact excess mortality over Africa? So what did we do? So basically we use the community atmospheric model, which is within the CSM, and then we just simulated aerosols under 3 time periods. So we did a pre-industrial aerosol simulation, present day aerosol simulation, and also we made a future projections of aerosols into the future. And we then use a health impact function to estimate how much people are dying as a result of being exposed to dust and open fires in the long term. So this health impact function basically is a standard function, and it just relates the changes in pollutant concentration to changes in mortality. So it uses the population of the exposed and also the baseline mortality rate and the attributable fraction. So here we use the population of Africa, the baseline mortality of Africa, to estimate how much people are dying as a result of being exposed to PM 2.5 from natural aerosols. Even though this natural aerosols like dust has been perturbed by anthropogenic activities, we still term them as natural aerosols. How dust and fires are causing excess premature mortalities for people with existing diseases like diabetes, respiratory infections, and other diseases. So here we show some results. So we have the dust concentration for present day. So we just show the simulation of dust concentration, fire concentration, and fossil fuel to the anthropogenic concentration for the present day simulation. So these are just annual PM 2.5 concentration from dust. So for the top panel here, we see dust is dominant in North Africa, and then wildfires dominate over the central part of Africa, whilst fossil fuel is also dominating the most part of Africa. So the histogram here is just showing you the annual PM 2.5 concentration from dust for all the 3 time periods, that's the pre-industrial, present day, and future. And the black line here is just representing the World Health Organization's air quality guideline of annual exposure level of 5 micrograms per meter cube. So in pre-industrial times, if we had the same air quality guidelines over Africa, we will see that even in pre-industrial times, dust concentrations were higher than the annual exposure level. So PM 2.5, so the air quality over Africa in pre-industrial times has always been bad if we had the same air quality guidelines that we have presently. And on this next panel, we're showing you the dust and fire mortality over West Africa. So we use the health impact function to estimate the excess mortality. And then we have so much people dying as a result of being exposed to dust and fires in present day. And so we can tell that the model dust concentrations is dominating over continental Africa. And then the sources of PM 2.5 over Africa mostly is the natural dust that comes from the North Africa and the biomass burning that comes from Central Africa. So it's a major takeaway. So we estimate about 30,000 annual premature deaths from being exposed to dust PM 2.5, and we have 20,000 from fire PM 2.5. And so overall, the concentrations of dust at the continental scale have changed substantially since pre-industrial times. But because of the lower population, so I said that we use the population of the exposed, but because of the lower population in these dust-dominated regions, they do not affect the health as much as the combustion as much as the anthropogenic combustion, like the fossil fuels. And so that's actually accounted for 36% of mortality for the pre-industrial and 35% for present day, and in future 36 of premature SF mortality. And when we take fire PM 2.5, that also changed since pre-industrial times. And in the future, under the SSP 3.7, we expect a decrease in biomass burning emissions. So the fire concentration is expected to decrease. Even so, this fire accounts for 40% of mortality in the pre-industrial times, 25% for excess mortality over Africa for present day. And in future, because we have lower emission rates and also lower concentrations, fire PM 2.5 is going to decrease by 14%. And also, the major takeaway, one of this is so annual concentrations of dust over continental Africa exceeds the World Health Organization, even in pre-industrial times. So we have lower air quality over Africa, and then we have to also get measures to improve the air quality, use air quality for natural dust, and not only concentrate on the anthropogenic fossil fuel and other industrial emissions. Thank you.
Thank you very much. We will invite our final speaker to share her screen. We're going to hear from Shibahu Saha from the U.S. Centers for Disease Control and Prevention. And we'll be hearing about the Association of Mental Health Impacts with Drought, a multi-scale analysis for the United States.
Thank you so much. I'll just put this on 1 second. Greetings, everyone. My name is Shibahu Saha. I am with the Climate Health Program at the Centers for Disease Control. Thank you so much for the invitation to come and speak to you. I'm going to present this work that we, sort of currently finishing up, looking at the adverse mental health consequences of drought. The climate change footprint on drought is quite well established, indicating how it's increasing in duration and intensity and in spatial extent. We also recognize that drought has a range of health consequences, both physical and mental health. And this study is, in particularly is trying to add to the evidence base that we currently have, which links, these adverse mental health consequences of exposure to severe drought. In the study, we have sort of two basic objectives. One, is to identify, some of the different mental health outcomes that we see strong associations with, and then try and see if these associations, how these associations, vary as we switch between different types of drought indicators. In this study, we have considered two different ones. One is, the information available through the U.S. Drought Monitor, USDM, which is probably, something that, most of us, see, in popular media when, drought is referred to. We have used the USDM, categories and sort of created these three, and we call them, none. The middle one is a moderate drought category, and the one which encompasses D3 and D4, we would sort of consider that as severe. We also look at the standardized, precipitation and evapotranspiration index, the SPEI, and, we use the SPEI ranges again, to sort of create, sort of analogs for the USDM, three category classification that we did again, severe, moderate, and no drought. In terms of the health information, we used hospital admission data for this particular analysis. The data came from about 20 states for the years 2007 to 2014. This data is essentially curated by the Agency for Healthcare Research and Quality, through the Healthcare Cost and Utilization Project database. These databases are essentially the entire universe of all hospital admissions, within these states. The data provides actually patient level information, with a variety of diagnosis codes, clinical diagnosis codes available, which we then used, to identify, these mental health outcomes. We initially started with this list, but, based on discussions that we had with, experts, we decided to, club alcohol and substance related disorders together. We clubbed anxiety and mood disorders together. And then we had suicide and, schizophrenia as independent outcomes. And then, we combined all of those into sort of a broader all mental health category outcome, just to sort of follow, what's commonly available in the literature, where, instead of, distinguishing between different mental health categories, much of the literature, actually ends up, combining these different mental health outcomes into a single indicator. So, we ran some, two-staged, hierarchical models. You see these mental health outcomes on the column on the left. This particular analysis uses the three USDM categories. And, the way to sort of read this table would be, if you look at the alcohol and substance related disorder row, the results show that, when there was, a severe drought, the months where there was a severe drought, there was a 1.63% increase in hospital admissions related to alcohol and substance related disorder when compared to a month when there was no drought. In terms of statistical significance, you can see that, both alcohol related disorders, schizophrenia, and then all mental health, were statistically significant. And you can see this sort of dose response function in most of these outcomes, where, the coefficient, when compared with the moderate category and the severe category, shows an increase. The next set of results are what we find when we, instead of using the USDM categories, we used, the SPEI categories. You can see that the statistical significance, when we look at the severe drought column, is greater when we compare the SPEI results, with the USDM results. But again, sort of the pattern, that we observed, the dose response pattern that we observed as we moved from, the moderate drought categories to the severe drought categories persisted, irrespective of whether we used, the SPI or the USDM as our drought index. And so, just to end, these are the results that we found for, when we looked at hospital admissions that are related to mental health. We recognize that we are probably capturing, the most severe manifestations of, these mental health consequences. We would like to look at, emergency department visits as well, expecting, that, we'll probably cover a larger number of mental health episodes, which might probably be less severe than what we see when we look at hospital admissions. We actually wanted to compare these results between rural and urban areas, as well as we wanted to make some regional comparisons to see how these associations change if we look at the southwest part of the country as compared to the Midwest and the Northeast. But we probably rely on a larger data set in the next few months, because this 2007 to 2014 period that we looked at in this particular study, we didn't see a huge lot of variation in drought outcomes across these different regions of the country. So thanks again for listening in, and look forward to questions.
Thank you very much. So we have a few minutes for questions, and there is, the one question was answered. So you can feel free to go ahead and unmute yourselves and turn on your video if you have a question to ask. If not, I have a few of my own. Okay, so this question is actually for AGU. Ambient data for PM 2.5 and dust and wildfire data is sometimes hard to come from. So my question for you was, what were the sources of your data for both the ambient and wildfire data from Africa?
Yeah, so we use the model, the CMIP. We got data from the CMIP models and then we have few limited observation data to compare the accuracy of our models. So we have like mostly CMIP models data. Yes.
Nice, thank you. And for Shubayu, I have a quick question for you. Have you considered looking at potentially the co-occurrence of hazards? So looking at drought in conjunction with other hazards that might, affect mental health, like wildfires or extreme heat?
I think that's a great question. Again, that's in the pipeline. You are, correct in sort of surmising that, the same set of outcomes are, potentially impacted by a range of climate hazards and not just drought. So we would love to, try and, bring together information on other hazards as well as we are, doing these kinds of spatial temporal analyses.
Thank you. I'd love to hear more because that's something that I'm very interested in doing as well. All right, if we don't have any more questions from anyone in the audience, I will turn the time back over to Azar to close us out and move into the lunch hour.
Thank you, Jen, and all our great speakers for a wonderful session. Thank you for being with us this morning and engaging in these discussions. We had a very active chat discussion as well. If you have missed it, you can check it out. We will now take a lunch break and be back at 1:30 p.m. Eastern time. You don't want to miss the afternoon sessions. We have 2 more sessions, very exciting sessions coming up. And we also have an environmental justice talk with Dr. Sesonika Ivy, and we have our second keynote for the day with Dr. Chris Eby. Enjoy your lunch. See you soon.